Friends, to another interview in 7th NUCD. Yesterday, you have listened to Professor C.B. Sanjeevi, the international researcher on immunogenetics and presently Vice Chancellor of Sri Sri Sathya Sai University. It is a pride, Professor Sanjeevi, to have you with us in this NUCD. And you have been a support and a pathfinder for many doctors in India for many years, last many years. And today's theme is diabetes reversible? The age-old question is, once diabetes, always diabetes. And even today, even 1 year back also, everybody was telling once diabetes, always diabetes. Has this concept started changing?
Alok, you'll have to
Professor
be very
Sanjeevi?
careful. Alok, you'll have to be very careful when you're using the word diabetes. It's not one disease, okay? It is multiple diseases all packaged and called as diabetes. So if you want to tease out various components of diabetes, various things that happen that lead to diabetes, you will say that many of the occasions you can reverse it. Many of the occasions you can even get rid of diabetes. Okay, it all depends on the contributions of your genes, how much contributing factor that is coming from the genes, then also in your lifestyle factor. Okay, if you do not have the genetic susceptibility for type 2 diabetes, if your lifestyle is the one that is cause of your altered metabolism, then you will realize there is much bigger scope in terms of decreasing the burden on your beta cells. And one of the paper that I just referred to in my talk, if you recall, this was a paper that was published in Cell. And there they had shown that fasting in an animal model causes beta cell regeneration. Okay, so beta cell regeneration is what is important in terms of diabetes. And in this beta cell regeneration, you also have to decrease inflammation. As long as the inflammation is an important component, as was very clearly described in several studies in my talk yesterday, you will realize that reducing inflammation, whether it is due yoga, whether it is due to exercise, or whether it is due to diet, or therapeutic diet, if you can call it, then the inflammation goes down considerably. And with this inflammation going down with some of the lifestyle approaches like fasting, you also have a possibility of the new beta cell being generated. So I would not accept the fact that once a diabetes is always a diabetes. There are so many reasons why you develop diabetes. It is probably 100 diseases packaged under one title called diabetes. So we cannot generalize the term and try to say once a diabetes is always a diabetes. But if somebody becomes all right, that doesn't mean that somebody is like everybody else. And with the new changes that are happening, with the new technologies that are coming, even in terms of stem cells, or with our own lifestyle, I would not think as we progress that once a diabetes is always a diabetes. But we have to be very careful in the using the word diabetes. One should not make it a common subject term.
Right. Absolutely, that is correct. But for the common understanding, we think type 1 diabetes, type 2 diabetes, gestational diabetes, FCPD, and all those. They are classified groups of diabetes with symptoms and different symptomatology. And many of them have a genetic background and immunological modifications. Being a researcher of genetics and immunology, do you think is it possible to change the pattern in these cases, in these people who have high blood glucose?
But in terms of current immediate practice, the answer is no. We don't have all the clues, all the tools available. But the way that we have been addressing this in the animal models, the answer is yes, it is possible. So we can modify the lifestyle. We can make changes where the genetic contribution is the most important part in a diabetic situation. But you should also remember that those people who have high risk genes, can spend their entire lifetime without developing diabetes if they follow a certain accepted lifestyle pattern, which is, I don't know what you would call it, a proper lifestyle, the ideal lifestyle, where you combine proper eating habits, exercise habits, and things like that. So it is a very loose term. And also, if you want to talk about various diabetic subtypes that you are just spoken, like type 1, type 2, these are all terminologies that we are giving. And these terminologies we ourselves have changed over a period of time. We called it IDDM, NIDDM based on therapeutic intervention. Then you changed it to type 1 diabetes, type 2 diabetes based on etiological parameters. Now the current thinking is more and more in terms of what kind of complications you will get, not in terms of how the disease has developed. So that based on the complications, you call them into 5 categories of diabetes. Okay, some of those categories clearly has higher risk for complications, whether it is renal complications or other kinds of diabetes complications. Now the pendulum is shifting, and now there was a recent paper that was published in Nature Medicine just last week, and the first author is called as Robert Wagner. Okay, if anybody interested, they can go and do a Google on Robert Wagner in Nature Medicine. The title of the paper is Pathophysiology-based sub-phenotyping of individuals at elevated risk for type 2 diabetes. What he is saying is, in those patients or those individuals who are pre-diabetic, by definition, they have not yet got the diabetic cutoff levels, he identifies one particular group of patients, I wouldn't say call it patient, one particular group of pre-diabetic individuals are much more prone to complication, even if they remain pre-diabetic, not diabetic, according to your cutoff criteria. Okay, here the cutoff criteria is something that you called it as 120 milligram percent some years ago. Then you changed it to 126 milligram percent. And now is 126 milligram percent the right cutoff? We do not know. So these definitions are something that we are giving, thinking that this will have therapeutic effect, but we still do not know whether these cutoffs of what you will call diabetic and non-diabetic is the right cutoff. Your body is not the same for everybody, because depending on a height and weight, your metabolic rate is also different according to individual. So you cannot categorize everybody in one setting. Basically, the individuals are so different. You'll have to look at them very differently. And immunology, and more than immunology, the genetics play a very important role. Hopefully, we will arrive in a nearby future where we should be able to screen the genetic markers that are helping you decide what kind of pharmacological intervention that you can provide. There are some patients who have mutations in some of the diabetic genes that will make them permissive for metformin treatment, and there are some patients without a mutation is not permissive for metformin treatment. So you are now treating diabetic patients with metformin if they are overweight, if they are obese, in your initial line of treatment. But that is not the right way to actually treat. If you can know the genetic composition, it should be possible to identify who is a responder, who is a non-responder. Whether it is insulin therapy or metformin therapy or any other anti-diabetic therapy, the therapeutic effect is also determined by some of the genetic composition. So genetics plays an important role, and hopefully in the near future, when we can sequence everybody, we can do what is called as precision medicine, where we give the right medicine to the right individual with or without the genetic mutation. So it becomes clear what we are evolving in our knowledge.
Taking a lead from this point, I would like to bring one question into discussion. Can gene therapy be utilized in reversal of diabetes? For instance, in 2018, the CRISPR-Cas9 was used to edit the CCR5 gene in twin babies in China to make them immune to AIDS. So in a similar way, can gene editing be used to make humans immune to diabetes? And how permanent or stable will this solution be in a person? Would this even be clear the current ethical standards in medical science?
As far as diabetes is concerned, Alok, the answer is no.
Multi-gene.
Because gene therapy is something that will be very efficient in single gene disorders. Okay, in there you can go and do the manipulation of the gene, remove the defective gene using CRISPR-Cas technology. You can edit the genes in a way that you want. Whereas diabetes is a polygenetic disease. There are too many genes involved. And so far, we even do not know what are all the actual genes. We keep increasing the number of genes that causes susceptibility to diabetes. So in this multi-gene disorder, gene therapy is not going to work. So that's not the solution.
Whenever we discuss of reducing diabetes, controlling diabetes, diet plays an important role. And the common practice is people eat more of carbohydrate and less of protein and fat, in particularly developing countries, Southeast Asia and all these places, not Europe, of course. Once you try to reverse diabetes or prevent diabetes in pre-diabetics, you have to cut carbohydrate content and give more of protein, more of fat, and that fat is healthy fat. Both healthy fat and protein are very costly. Do we have a solution to this? Is it then that means that reversal of diabetes is only a choice of rich, not for the poor or common man?
Alok, it's a very interesting question. When you look at the management of diabetes from a nutritional perspective, calorie restriction is important, okay? But that is not the mantra for getting diabetes under control. So if you take 2000 calories, but if the 2000 calories a day is filled with fat, that's not going to be beneficial. Okay, or if you have the 2000 calories with less carbohydrate and less fat and more protein, will that be beneficial? So you cannot actually look at nutrition from a calorie perspective, or you cannot look at nutrition from the point of view of composition of your diet made of carbohydrate versus protein versus fat. But you should also look at what I would call it as therapeutic nature of the food. So protein, carbohydrate, and fat do not constitute diet alone. There are a lot of minerals, there are a lot of elements that are very important, which I just described in the Okinawan diet, where low calorie diet that are less in carbohydrate, more in protein, but that has a lot of minerals and other important ingredients that could be plant-based, could be having a major therapeutic contribution. So when you're looking at the diet, it's not just the calories, it's not just the consumption of certain percentage of carbohydrate, protein, fat, but you'll have to take into consideration the kind of gut bacteria that you have. Okay, so if you do not have the right kind of gut bacteria, which is called a second genome in your body, your two sets of chromosomes that you had inherited from your father and mother is the primary genome. The second genome in your body is billions of bacteria that are sitting in your gut. That makes a lot of influence in terms of what you eat, how much it is accepted, how much it becomes toxic. So when you look at this, it's not such a simple thing. So when you want to treat somebody from a nutritional perspective, calorie restriction is one aspect. That's not the only aspect. Then composition of the diet in terms of carbohydrate, protein, fat is another aspect. But that's not the most important aspect too. The important aspect is the therapeutic nature of the diet that you give. And if you come across a therapeutic aspect of the diet, which is now coming out to be a major important aspect for nutritional therapy, drug intervention is one form of therapy. Nutritional intervention from a therapeutic perspective is also another form of therapy. So the nutritionist should also look beyond the calorie restriction, look beyond composing food with certain percentage of carbohydrate, protein, fat, but to the therapeutic nature of various minerals and other components that you could have in relation to the gut bacteria. So it is getting complicated, but we cannot simplify by asking somebody eat less. But what he eats less also becomes important. If you eat less and if you have less carbohydrate, but it has more mineral and other important compositions that are beneficial to your body, then it has a great value. Turmeric is one such important aspect, and curcumin has been considered to be so beneficial in so many situations. But we need to look at beneficial effects of all these things in terms of cell integrity, in terms of cell stability, and in terms of the cell membrane stability, and in terms of protecting the cell from dying. And all this is relevant from the point of view of beta cell stability also. So many of these minerals and components play a very important role. So we should not make a nutritional intervention in a very simplistic terms.
Right. So when we think of diabetes, reducing diabetes, preventing diabetes, we can control glucose by any means or that. By exercise or by diet or therapeutic diet, we can do that. But just by controlling glucose, are we doing all good to our patients? They will still continue to have nephropathy, retinopathy, cardiomyopathy, and all those things, because it has been seen in pre-diabetics, 14% people have retinopathy, whereas diabetic 21% have retinopathy. So what is your take-home message for our doctors, that complications, how should we deal with diet or anything else by reversal of the method?
So when we are treating somebody whom we are calling them as diabetes, and our primary target is decreasing the blood glucose level to an acceptable numbers that you had defined, okay, this probably may not be the best approach, because but the ideal approach is something we still do not know. So we are trying to improvise. But if I would like to refer back to this paper published in Nature Medicine, where they are talking about pathophysiology-based phenotyping of individuals at elevated risk for diabetes. They clearly have 5 categories. It is not the same 5 categories that the Swedish researchers had come up with and published in Lancet. So here they have different categories based on the risk factors: moderate risk, high risk, low risk, and they are categorizing them into 6 clusters. And they say that 1 or 2 of these clusters, in spite of having pre-diabetic blood glucose values, you know what pre-diabetic blood glucose values are, those individuals, in spite of either fasting hyperglycemia alone or one of the intermittent values to be abnormal, where the fasting blood glucose values is normal, you will not call them diabetes, right? But these individuals develop renal complications, develop other complications that are associated with established diabetes. And your established diabetes are people with abnormal hyperglycemia, and with your drug intervention, you try to bring the blood glucose level to below 120. Comes down mechanisms that are leading to the development of complications, especially renal complications. And I would strongly recommend people to read this wonderful paper that makes it very, very interesting. Where some of the parameters that you just described might sound good, because that's exactly what people have been talking. But the new information, knowledge that is coming out is challenging all these concepts.
That means with reversal of diabetes, reversal of complications may not occur or will not occur.
If you look at diabetes from a blood glucose point of view, that's true. If you look at diabetes beyond the blood glucose point of view, where you take into consideration so many other factors that are operating in the body, just now I mentioned, including the gut microbiome, there's going to be a different outcome that we have not yet studied in great detail to understand in terms of determining who will develop complications. You might find some people have had for a long period of time still don't progress to renal complication or cardiovascular complication. Whereas some people who have had HbA1c values abnormal only for a short time and have had good HbA1c, they progress faster. So this makes you think that there are other factors that are important other than HbA1c or blood glucose values But we need to really look at a newer way of thinking and addressing this. But it's more than blood glucose is what I
Sanjeevi,
would
it was
say.
nice talking to you. Thank you very much for finding time for NUCD 21. And the take-home message is very clear. Reversal of diabetes is still in the research phase, and possibly what is happening is remission of diabetes, and complications are not reversed in diabetes yet. We have to wait, find out newer modalities, new research, and as you have told, diet should be used as a therapeutic agent. Thank you, Sanjeevi, for all the time and all the messages given to us.
Thank you, Alok. It's a pleasure.
Thank you.